Hi, I'm John Levy from the Levy Shoulder to Hand Center at the Paley Orthopedic and Spine Institute. And today, we're going to talk about frozen shoulder syndrome. Frozen shoulder is possibly the most common thing that I see in my office, and actually one of the least common reasons that I have to operate on a patient. It's real common for patients to present with a variety of common symptoms: pain, limited motion, a dull ache around the shoulder or sometimes down in the upper arm. But the hallmark of a frozen shoulder is a loss of motion. What is meant by a loss of motion? Can't reach up your back, can't rotate out to the side, difficulty bringing your arm above your head, and when it starts to really affect you, you have difficulty sleeping. And while you may not have pain in early parts of movement, when you reach the extreme portion of movement, the pain becomes severe. And that happens really quickly when you go to grab an object or something that requires you to go through a full arc of motion fast. In general, this will affect probably about 2 to 5% of patients, and there are certain at-risk populations. We know that women between the ages of 40 and 60, or those patients who have diabetes, not really relevant whether the diabetes is well controlled or not, just the mere fact of having diabetes or thyroid disease. And then there are a group of patients that have had trauma or prior surgery that can act very much like a frozen shoulder as well. It's interesting that up to 35% of patients will actually develop frozen shoulder in the other shoulder at some point in their lives. So it's just something to be cautious about. What's actually going on in the setting of adhesive capsulitis or frozen shoulder is a thickening and tightening up of the joint lining inside the joint. So all joints have moving parts, the two parts of the bone that move, but in all joints they're covered by a joint lining called a capsule. And in the shoulder, when that capsule becomes irritated and inflamed, it doesn't like to be stretched, and anything that creates a stretching event will cause pain. And it's typically a sort of a three-stage process, or what we call the natural history, meaning if left untreated, this is what would happen. And you can see here in this slide the overall 3 stages of adhesive capsulitis as you go through the freezing stage, the frozen stage, and then eventually the thawing phase. When I evaluate patients, in addition to an examination, I will always get an x-ray. Because really, one of the main things I'm trying to differentiate between is the amount of arthritis that's present, and I can see that very clearly on a plain set of x-rays. So we typically in our office will get 4 different x-ray views, and by looking at views from different angles, I can get a sense of whether that shoulder joint looks normal on x-ray or whether there is an advancing arthritic process. An MRI, when an MRI is done, will show really a lack of findings, meaning there is no full thickness retracted rotator cuff tear. There may be some inflammation inside the joint, fluid that might track along the long head of the biceps tendon, an additional thickening of the joint lining or the capsule, which you can see on certain cuts. But a lot of times the MRI might be misleading. Things like partial thickness tears or labral tears are often part of many of the readings that you get on an MRI that may not be truly relevant in the setting of adhesive capsulitis and might direct you to go down the wrong course of action into a surgical treatment where I think, as we'll get to in a second, I always try to beat this without an operation. I always start with non-surgical treatment for this, and that consists of a combination of modifying your activities, an intra-articular cortisone injection. And now, of course, in those patients who do have diabetes, we have to be a bit cautious because blood sugars can go quite elevated after a cortisone injection. But it is something that certainly can make a difference in the recovery process. But probably the most important aspect of the recovery process is a stretching program. And I'm a firm believer that doing stretching every single day as part of what we call a static progressive stretching program is the secret to success in this. 3 times a day, stretching in 4 different directions. Each stretch is a stretch and hold to about 60 seconds of stretch, repeating each of the 4 exercises three times and doing it 3 times a day. And that program of a cortisone injection and a home stretching program, in my experience, works about 90 to 95% of the time. Obviously, not everybody gets better. And in those select cases that have been struggling with this for quite a while, surgery can be an option. And when it comes to surgery, for those patients who have a frozen shoulder, surgery is actually a very good option at resolving the problem. And what I do is an arthroscopic capsule release. And what you can see on the picture on the left is the capsule that gets snipped with a specialized microscopic scissors through a minimally invasive approach as I release the joint, free up the motion, start therapy the next day. And so I hope this was a good explanation for what frozen shoulder is all about. And of course, if you are experiencing a frozen shoulder or think you might have a frozen shoulder, definitely see an orthopedic specialist. Certainly our office at the Levy Shoulder to Hand Center has many experts in our group who are taking care of frozen shoulder every single day. We'd be happy to take care of you.